Hi guys, my name is Sanjay Gupta. I'm a consultant cardiologist in York, and today I wanted to talk to you about the subject of Afib and the difference between valvular and non-valvular Afib. Okay, so this is entitled, let me just get this on. Here we go. This is entitled Afib, valvular or non-valvular. So the first thing to understand is, why is this an important question? Why is it important to know whether your atrial fibrillation is valvular or non-valvular? And the simple answer is this, okay, that these days there are a new class of agent, new class of drug available to reduce the likelihood of having strokes in people who have Afib. Whereas previously, all that used to be available was warfarin. Now you have these new agents called NOACs, okay? And the problem with the NOACs is that they are licensed for non-valvular Afib. And therefore, for a lot of people who want to go on these agents, there is a dilemma because they don't know whether their Afib is valvular or non-valvular. It's important to realize that a lot of people do have some valve disease, particularly as you get older. So if you also have Afib and you are found to have some valve disease, does that mean you have valvular Afib, or are they two separate things? If it is valvular Afib, then as per licensing laws and recommendations, you are not suitable for NOACs. If on the other hand, you just have valve disease, which is not related to your Afib, then you would be suitable. And therefore there is this confusion amongst a lot of people about what is really non-valvular Afib and what is valvular Afib, okay? And usually the main reason is really with regards to whether you're eligible for a NOAC. The obvious advantage of the NOAC is that it causes NOACs cause less likelihood of bleeding in the head compared to warfarin. And they don't require the monitoring, i.e. the regular blood testing that you have to have when you're on warfarin. So they are obviously advantageous in lots of ways. And if I ever had Afib, then I would certainly want to go on a NOAC. But if I then went to my GP or my doctor and he said, well, look, you've got some leaking of your heart valve, and therefore I think you have valvular Afib, you can't have a NOAC because NOACs are licensed for non-valvular Afib. And so let me just talk to you why people get valvular Afib, and then why, what valvular Afib is, and then I'll talk to you about who can have a NOAC. Okay, so this is your heart here. All right. Now these are your valves. So this is your tricuspid valve. This is your mitral valve. All right, your mitral valve, and this is your aortic valve. All right. Now, if you have a problem with one, and this is your atrium, this is the chamber here, which is the chamber that stops working in AF, in Afib. So if you have a problem with your valve, your mitral valve, let's say you have a very leaky valve, what tends to happen is that the blood will go into your heart, and instead of it all going out through this valve to the rest of the body, some of it leaks back in, all right? And then what happens there is that because less blood has gone to the kidneys think you're dehydrated, they absorb more water from your urine, and they try and replenish the circulating volume by absorbing more water. So in essence, what you have is you end up having more blood. But the kidneys then think, oh, well, we've now replenished the circulating volume. We expect to get the amount that we are used to. But again, if you have more volume and still you have some leaking this way, then your kidneys will still get less, and you can get into this vicious cycle. And what that means is you get more and more blood, and eventually what tends to happen is that the atria start stretching because it's having to accommodate a lot more blood, and the pressures in the heart gets higher, and therefore the atria stretch, and eventually the patient develops AFib. So that is considered valvular AFib. Okay. Similarly, but that's only if you have severe leaking of your heart valve. Similarly, if you have a narrowing of this heart valve, it's called mitral stenosis. Again, the blood cannot go into the ventricle as easily because this valve is narrowed. The atria have to work much harder. They get bigger and bigger, and then because they're getting bigger and bigger, they eventually fail, and that condition is called AFib. Similarly, if you have a problem with your aortic valve here, if you have a problem with your aortic valve here, then what tends to happen is the blood cannot be ejected as easily. So the blood doesn't go to the rest of the body as easily. Therefore, the atria have to push blood in because the pressure here is high. They have to work harder, and with time, they get bigger and bigger, and eventually they stop working and you go into AFib. So that is what valvular AFib is, all right? And non-valvular AFib is obviously when the AFib is not due to that. Now, from the point of view of being on NOACs, at what point are you thought to have valvular AFib, i.e., when are you not eligible for a NOAC? And the truth is, there are only two conditions in which you shouldn't be on a NOAC as things stand. The first is if you have a condition called mitral stenosis. Okay, if this valve is tight, narrowed, okay, especially if you've had rheumatic fever in the past, then they consider the risk of clot formation so high that it hasn't been adequately studied in the trials, and people who have moderate to severe mitral stenosis should not go on a NOAC. Okay, so the first condition which would make your AFib valvular is moderate to severe mitral stenosis. Okay, a narrowing of the mitral valve, which is this valve here. The second condition in which you shouldn't have a NOAC is a mechanical heart valve. So if you've had a problem with your valve and you've had to have a metal valve put in instead, then you should not go on a NOAC. And the reason behind this is that there was a study called Realign, and in that they actually gave people who had mechanical valves a NOAC, and they found that those patients had more complications than warfarin. So unfortunately, if you have rheumatic mitral stenosis, which is moderate to severe, or you have a mechanical heart valve, i.e. a metal heart valve, then you should not go on a NOAC and you should stay with warfarin. However, if on the other hand, you have any other valve pathology, like mitral regurgitation, if this is leaking, you can still go on a NOAC. If you have aortic stenosis, a narrowed aortic valve, you can still go on a NOAC, okay? If you have a pig's valve, if you've had a valve replacement, but you have a pig's valve, then you can go on a NOAC, but it is generally recommended that you shouldn't do so for the first 3 months after having the operation done. Okay, so for the first 3 months after your pig's valve has been put in, you shouldn't be on a NOAC, and you should probably be on warfarin. But after that, you can go on a NOAC. Remember, people who have pig's valves do not require do not require anticoagulation for the valve. All right, and therefore, if you develop atrial fibrillation, you are being anticoagulated for the atrial fibrillation, and you can go on a NOAC. People who have metal valves need anticoagulation for the valve, and therefore, if you develop AFib, of course, you need to be anticoagulated for the AFib, but you need to make sure that that anticoagulation also works for the valve, and that is why those people should be on warfarin. But people who have pig's valves can take a NOAC, but usually after the first 3 months of operation. Now, what about people who've had a repair of the mitral valve? Some people undergo something called a mitral valve repair as opposed to mitral valve replacement. So the valve is not removed, it is simply repaired, and you're left with your own valve, which has been repaired. And again, it is said that those people can have a NOAC, but it is generally recommended that they should not have it for the first 3 to 6 months after the procedure. Then there is a condition called TAVI. There is a procedure called TAVI. Nowadays, what can be done is, particularly if you have a problem with this valve here, the aortic valve, people can put in a valve through keyhole. So they can do this thing called TAVI, or percutaneous transfemoral aortic valve implantation, where they actually put a valve through one of the arteries in the legs into the heart. And that thing is called a TAVI, okay? And the question is, can patients who have had a TAVI go on a NOAC? And the answer is yes, they can. There are no real data, and it is possible that some of these patients may, in addition to a NOAC, require an antiplatelet like aspirin, but a NOAC is not contraindicated in these people. There's one other condition that people often worry about, and that is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is an inherited condition where you get excessive thickening of this heart muscle here, and if you do, then what can sometimes happen is it can obstruct blood flow out of the heart. Okay, and the stroke risk in people who have hypertrophic cardiomyopathy is much greater, particularly with Afib, and therefore people have always been wary about prescribing the newer agents, the NOACs, in those patients. But the truth is that although there are no studies, people who have hypertrophic cardiomyopathy would also be considered eligible for a NOAC. So for the purposes of NOAC prescription, the only patients who should be considered not eligible for NOAC treatment are people who have moderate to severe moderate to severe mitral stenosis, and secondly, people who have metallic heart valves. All right. Other than that, virtually all of the patients who have AFib can go on NOACs, are eligible for NOACs. I hope this will be useful if it ever comes to you wanting to go on a NOAC and you're finding that, okay, I don't know whether I'm eligible, or maybe your GP says, look, I'm not sure whether you've got valvular AF or non-valvular AF. You can feel very confident about saying that there were some recent guidelines produced in a journal called Europace. Okay, now let me just try and see where this paper is. I'm going to try and, so they were published in a journal called Europace. They were published on the 31st of August 2015. The lead author is Heidbuchel, Heidbuchel, and he was the lead author of this. And this is where my data and my information comes from. So if you ever have any doubts, you can check this paper out on PubMed or on Google and show it to your doctors should you want to argue your case for being on a NOAC. I personally, if I ever had a choice, would definitely want to be on a NOAC if I had AFib, just because A, it's convenient, but more importantly, I think it's safer compared to warfarin. So I hope this was useful. Let me just, my mouse isn't working. Let me just bring this in here. So thank you so much for listening. I really appreciate all your comments. I really appreciate all the nice things you say. I'm very grateful. I'll try and do some more videos. It's just been very busy recently. But if you need to ask me anything, you can visit my website or come onto my Facebook page. And in fact, love it when people interact with me on my Facebook page. So there it is. I don't know how you get to it, but you can type in yourcardiology@gmail.com and it should come up. And this is me. All right. So thank you so much. And I look forward to speaking to you soon. All right. All the best. Take care.